Another set of pictures of essentially the same operative procedure by another group of ocular surgeons from France. Here is a patient with a rather striking tarsorrhaphy, which is a rather unpleasant procedure that we like to hope that the gold eyelid implants will obviously avoid. Patients with trigeminal and facial paralysis often need a tarsorrhaphy as well as a gold eyelid weight because of the absence of sensation in the cornea. But the tarsorrhaphy in that instance, if the gold weight is present, can be less extensive. Here we are showing the use of our testing kit, which at the time of these pictures were taken was using little weights of sterling silver. We are now using tantalum weights, which are smaller because tantalum is heavier than silver. These are used with an adhesive attached to the lid and give us a good estimate of the amount of gold that will be needed. We prefer to use enough weight so that the lid closes more than is normal, because the levator will become stronger as it works against the weight. Our kit has 7 weights extending from 0.6 to 1.8 grams in 0.2 gram intervals. If you need more weight, it is possible to get almost any reasonable accommodation by joining 2 weights on the same eyelid. The gold eyelid weights that are being used in these pictures are somewhat different from the contemporary ones, as they were at the time only curved. Now they are shaped in a spherical manner to better fit into the eyelid tissues. Here is the tarsal plate being identified. As you can see, one edge of the implant is more tapered than the other. If the implant is being placed at the lid margin, it is better to have the tapered edge up. If it is placed higher in the eyelid, the tapered edge should be lower because it makes a less conspicuous edge in the overlying skin after the wound is closed. As you can see, the operation is performed very much the same from case to case. One thing that is always of interest to me is the fact that gold eyelid implants do not appear to make it difficult for patients to close their eyes when they're lying on their backs. I presume that is because it is in front of the orbital septum and not directly on the levator. Cutting tarsorrhaphies is an appropriate accompaniment of this operation where it is indicated. It's important to avoid placing the deep sutures through the conjunctiva when suturing the implant in position. This surgeon places a silicone plug into the inferior punctum when he does this operation as an additional assist in the problems associated with facial paralysis in the eye. Again, you can see the result. The closure is present but not brisk, but is distinctly helpful. In this instance, you can see that the exposure has had some damaging effects on the cornea.